Get us started. We are a little bit on this time crunch here. I take it at least a few of you have flights that probably will be leaving Atlanta very soon after lunch. Those of you who are not, once again, I encourage you to spend your remaining dollars before you leave the city of Atlanta. We appreciate it. Thank you. So, here we are at lunchtime, and we're going to have a little conversation, even as you read, about public-private partnerships and some of what we know is work and what's going on. We have two gentlemen with us today. I think you might know the names. If you don't, you will certainly know it after they're done, who will speak to us a little bit about their own experiences. I recognize that it's lunch, and that there'll be maybe a little bit of a cacophony of spoons and bowls and that kind of stuff, but to the extent that I think the microphones will amplify beyond that, we're going to kind of push ahead. So I'm going to introduce them both, and then they'll speak to us. Once again, I'll ask you if you have questions, just kind of make note of them. The microphones are still in the audience, so if at any stage of the game you have a question or a comment, I invite you to make your way to the microphones and bring that to the whole room. So with us today are Don Bradley and Brian Castrucci. Don holds a position as the Associate Consulting Professor in the Department of Community and Family Medicine at Duke, and serves currently as the Executive Director for the Practical Playbook. He also continues to work with the North Carolina Healthcare Quality Alliance, the National Academy of Medicine, Health and Medicine Division, that was previously IOM, and is a part of the Roundtable on Obesity Solutions. He's retired from Blue Cross Blue Shield in North Carolina, so he brings that background to both the work in this conversation, and we look forward to hearing from him today. Could you welcome him, please? Brian's Chief Program and Strategy Officer at the Beaumont FOUNDATIon. He's spent a lot of time working to improve population health and working with multi-sector collaboratives in that effort and strengthening the public health infrastructure throughout the country. In doing that, he's developed several national programs, including the Practical Playbook, the Build Health Challenge, which I think he will say a little bit more about today, the Public Health Workforce Interest and Needs Survey, and City Health. He is an epidemiologist by training and a public health leader, and has spent quite a bit of time involved in publishing and doing public health systems and health services research. Could you welcome him, please? And so I'm going to take my seat this time there, because it just feels like I need to be closer to my soup. And listen as they speak, and then I'll be back up to facilitate the Q&A that we may want to have immediately after that. Could you please join me once again in welcoming to the podium Don Bradley.
Good afternoon. It's been a pleasure really to be with you. I came early yesterday morning to make sure I understood what you guys were about. And what I want to do is, and I would note that yesterday you talked a lot about data, and I've also heard a lot of talk about relations. So I'm going to try to pull that together with my own, if you will, personal journey, and try to make some points and maybe hopefully some insights related to the meetings that you guys have been having over the last 2 days. Let me ask a question. How many here work in public health? Okay, a lot of public health. How many in healthcare? Just a few. Okay. How about community organizations, community-based organizations? A few. Okay. How about payers? Oh man, it's lonely up here. Okay, great. So most of us got into this arena because we want to help people, and that's really where I started. While I have some kind of national work that usually shows up on my resume. My background started as a family doctor in rural Southern Virginia and worked there. And I thought, I can really help the people. And actually, relationship and collaboration was a big piece of it. I think that's one piece that we don't understand that rural communities often bring to the table that we shouldn't ignore. But I wanted to impact a larger group, have a bigger impact on what was going on. So I actually moved to Duke, where I ran the clinical practice for the family practice residents, 50 docs, 39 residents, and it felt good. We're now training people to go out and have an impact. And I thought, well, that's okay too. So I moved then to Blue Cross Blue Shield in North Carolina to be the executive director for their HMO and ultimately their chief medical officer, and really working on their programs. And while I was at Blue Cross, there were a couple things that I thought I was really helping with. One is I helped set up the first bariatric surgery centers of excellence in the country, which I can assure you was a collaborative effort. It's working with surgeons, and those of you who tried to work with surgeons know that can be an interesting process. But we did it, and it really, and the reason for doing that was that our health plan covered bariatric surgery, but we were seeing complication rates in the range of 25 to 50%. Huge expenses. And what a number of health payers did was to say, well, one way to stop the complication rates, because it was national, is to stop covering the benefit. And that happened. My take on that was, that's great. You're leaving people with severe obesity without much of an opportunity to get healthier. So that we did that. It worked out actually really well. And I thought, well, okay, maybe we need to go from a medical mindset a little upstream, and maybe we want to prevent people from moving to having severe obesity. So we started the first benefits covering nutritional counseling for obesity. So again, I think this is the kind of thing that I want to have us detail. And along the way, well, actually, being an academician, I have to give you learning objectives. So essentially, synthesis means I'm going to tell you my story and how I got here. And then the second piece is to talk about strategies and tools, and Brian will do a bunch of that. So here are some of the data points, going back to the data, that I look at when I think about the issue of obesity and health writ large. This is where we spend the money in this country. So it may be a little small for the folks in the background. You'll have these slides later, but 3% goes to public health. 85% goes to personal health care. And you match that fact with where you get help, and this is County Health Rankings model. There's actually similar models that come out of the medical literature as well, where healthcare, County Health Rankings is generous. They talk about 20% of the impact of health comes from health care, but really more of it is related to behavioral factors, socioeconomic status, and environment. So that's kind of a mismatch. And when you put that together with where, kind of how we distribute the money, and this is a study done by Elizabeth Bradley, who unfortunately is not related to me. But she looked at, we hear about the American health care system is more expensive by far than any other health system. But if you take the United States spending on both social systems, social care, and medical care, we actually come out in the middle. So that overall, but what you'll also notice in that is that the ratio of healthcare expense to social expense is really totally out of whack. So it's really about 2 to 1 on healthcare, And if you look at some of the best performing health systems internationally, they're to the right, the ratio is flipped exactly. So it says to me that we really need to be thinking about, at a systems level, about really moving towards spending a lot more of our effort upstream. And this is where I got involved with the Practical Playbook. So I retired from Blue Cross Blue Shield. I was a very young retiree. And actually ran into some folks at Duke who said, well, you know, you've got nothing better to do, why don't you come work with us here? But the Practical Playbook has at its core is to improve the health of populations through robust collaboration. The recognition that this program has is that we're not going to do it alone. You know, we can shift money to different pockets, but unless we really begin to work together, we're not going to get there. So, and the particular things that we do is that we connect people, and we work primarily at an organization-to-organization level. Because oftentimes I find folks don't know that they've got people almost sitting next to them that are doing similar work. And that there can be real synergies, but it can also be counterproductive if you're kind of fighting over the same pot. The second piece that we do is to try to accelerate by using tools, and then finally to develop the capacity and capability of organizations to do the collaborative work that we think needs to be done. The specific things we do, and I'm not going to read these out for you, but we do have a website. So we heard about the data tools yesterday morning. We have a number of resources there. I'd encourage you to look at it. We actually have a hard copy version of some of this. Brian was actually one of the editors on that. But the most exciting work for me is with the Build Health Challenge. And this is now 37 communities across the country who are coming together on what we say, the acronym for BUILD is bold, upstream, integrated, local, and data-driven. So these grants, it's funded by Robert Wood Johnson, Kresge, the Beaumont Foundation, the Kellogg Foundation, the Colorado Health Foundation, the Advisory Board. So it's actually an interesting collaboration of funders who are asking communities, a community-based organization with the governmental public health department and a health system, to come together and work on an upstream determinant of health of their choosing. And to me, that's kind of the nugget. It's really getting people to do it. The issue that I have, even in doing this work, is, you know, I spent the first 2 years with Practical Playbook trying to convince, particularly public health folks, who tend to be, as you heard earlier, programmatically oriented. As you know, why do you need to collaborate? Why do you need to get out of your silo? And that's great. And actually, I think public health has come a long way. Public Health 3.0, you know, most folks kind of understand that, and they actually almost believe it most of the time. And then it gets to going from why to what do you do? And we heard a lot of that during the conferences. What are people doing? You know, what are the programs? What are the types of things that we can be doing together? But to me, that still doesn't get to the point of how do you do it. So, you know, moving from why to what to how is really what we've been working on with the Practical Playbook and the Build. These are the communities in our second cohort of the Build Health Challenge, folks. And I'm willing to bet that if you live in one of these cities, there are 19 of them, I bet there's a better than 50-50 chance that you don't know that grant has been given. Now, in fairness, they just announced September 12th, so you're not that far out of date. Now, they're not all working on obesity. In fact, a good number of them are working on housing and built environment and so on, although they do relate to a large extent to to obesity. But if you have a build health community where you live or work or near where you live or work, I would strongly encourage you to figure out, and you can go on the website and get the contact information, just figure out what they're doing and whether you can play a part in that. And at least, on paper, for the filling out the grant, these folks are supposed to have a public health department involved. So this moves to kind of my, again, more of a how. The two lessons that I've really pulled out of working with both the National Academy of Medicine and the bill and the Practical Playbook are really twofold. The first one is about relationship. Again, there's been a lot of talk about relationship here, but the how of relationship is what I think is critical. And I want to point out that relationships and trust go hand in hand, and change proceeds at the speed of trust. So if you're trying to build a relationship, unless you have trust, it's not going to go very far. You can sit in the same room and have a meeting, and you can call that collaboration. But until you have a relationship which is based on trust, you're not going anyplace. And I think there are specific pieces that I have to look at least for myself, in building trust and relationship. And the first is credibility. So I am an old white guy. And when I go into downtown Durham to start talking about a project, my credibility is suspect just because of who I am and frankly where I come from. So I need to build relationships with other folks before I go in, and part of that credibility is listening first before I start talking. So finding credibility, and if you don't have it, figure out where you can get it. Now, those of you in public health have a lot of credibility because you do have data, you have a lot of knowledge, but really moving that to the point and understanding when you do and don't have credibility is critically important. The second piece is authenticity. Now, this is a millennial word. Millennials are really into authenticity, but I got to tell you, most communities are into authenticity, and they can smell it when you don't really mean it. And you've got to go in and do you really mean you're going to work on health equity? And if you kind of put your health equity, slapped it onto the back end of the project that you started 2 years ago, that doesn't feel very authentic. So thinking about authenticity is the next piece. The next is reliability. Are you there to get your research study done and you're gone? Do you have a program that's going to last a year and you're gone? Are you going to continue a relationship when you're gone? When the project's done? Folks build relationships with folks that really they can rely on. And then this is one that I find particularly reciprocity. This is particularly true with the public health departments that I've worked with. Public health departments and the folks in this room are all doing great work. They're doing God's work, if you will. It's the right thing to do. But if you're going to go talk to a business or a health system, what are you offering? The comment was, if you're asking for money first thing in the door, without saying, well, here's what I can do for you, then you're not building a relationship. You might as well be the guy standing on the corner with the sign saying everybody needs help. So, and you guys do have a lot to offer. First of all, you have data. Most of these, particularly health systems, and that's one of my backgrounds, is they need to hit certain metrics around their value-based payment. You can help them with that because they're not going to get it done on the four walls. And the final piece is empathy. I think really being heartfelt. Now, I would differentiate sympathy from empathy. Empathy is understanding feeling, not weeping and wailing about it. It's really, I understand how you're doing. So that's lesson one. Lesson two, this is a Henry Ford quote that I love. Coming together is a beginning. Keeping together is progress, which is a lot of where I think we are. Staying together and working together is success. And again, when we look at the Practical Playbook, the collaboration in and of itself is success. So if you're, particularly on a topic like obesity, you're not going to drop the BMI of your community in the space of 2 years. It's going to take longer than that. So staying together is a piece of it. And I wanted to cite 2 pieces of work that I've been involved in with this. One is through actually a generous grant from Robert Wood Johnson. We've been working on building competencies for obesity prevention and management. And this is interprofessional competencies. So what we did under the aegis of the National Academy of Medicine's Roundtable on Obesity is to pull together 12 different health professions representing 16 or 18 different organizations. What does every profession need to know? And by the way, when I say health professional, I don't mean doctors and nurses. I mean doctors, nurses, pharmacists, public health folks, social workers, clinical health workers, dentists. So we pulled these folks together and come up with a list of competencies that everyone should know. Now, not everybody needs to know at the same level of detail about this, but one is knowing, basically what's obesity about? What's some of the physiology? It's not just, so how many people here believe that obesity is just calories in, calories out? Good. You got at least a piece of number one, okay? But I got to tell you, there are healthcare professionals and health professionals that continue to do that all the time. How many people here think that really obesity is related to a person's lack of will? Okay, this is preaching to the choir. But again, those kinds of myths continue on, and that's a piece that we think is important to continue. The second is knowing a bit about the epidemic and the epidemiology of obesity. One of the most startling facts that I've seen recently is when, at what stage of life do you see the largest weight gain? It's actually between childhood and young adulthood. That's where you're seeing the most, and that is not a place that we're paying attention to right now. I think early childhood development is important, but we're kind of missing a piece in here. So again, just understanding the epidemiology. The third is to talk about disparities, inequities that obesity places on different populations. And then we get to the interprofessional care, which I think is, to me, the center of this piece, and I'll talk a little bit more about that in just a second. The other thing we have is talking about interactions with patients, and I will tell you, being someone who thinks about the linguistics of this, is I would have preferred that our group not use the term patients. I think they are persons, and that there are people who are not patients, who are persons who have obesity. Second is using, and we talked about this in one of the healthcare groups, using person-first language. People with obesity are not obese people. An obese person is a characterization of someone, and it carries with it a number of connotations that oftentimes are not fair. They're weak-willed, they don't know, they don't care, and when you look through the medical literature, you'll see a lot of this. So we've got plenty of work to do in that line. We talk about bias and stigma. For how many people here have taken one of the Harvard IAT or implicit association test things? This is a test that says, okay, where are your biases? And we all have them. But obesity turns out to have one of the highest biases in the 16 or 18 different metrics that they look at, more than gender, more than race, so that we all have some biases, and figuring out, first, that I have some biases, and how I'm going to deal with it is important. And then we get on to the more clinical piece about accommodations and so on. So let me go back to the interprofessional side of this, and particularly relevant to this group, I want to focus each of the competencies, the high-level competencies has sub-competencies. And the one that I want to particularly pay attention to is that one of the competencies is to collaborate with community organizations to advocate for nutrition and physical activity services programs and our policies to address obesity. And that means public health has got to get out of the public health silo, healthcare's got to get out of the healthcare silo, community-based organizations need to reach out, and to really even think about different partners. Some of the best partners that we've seen working together include businesses, payers, faith communities. So again, we've got to be a little bit more creative. This is the link to these competencies. And finally, I'm going to we've also built a model for, and this is kind of the health systems, and if we had another hour and a half, I would go into this. This is another piece of work that we've done, and really point out that linking the clinical side and the community side is critically important, but also to understand that the patient and the family are what we're really here about. It's not about who gets credit or how we relate to each other. It's both patient and family. So you can look at these resources. A number of them you heard about: county health rankings, community commons, playbook. There's a number of these things I would welcome you to look at. So with that, I'm going to turn it over to Brian.
Thanks, Don. So, that's like a good talk. It's hard to follow. Don's like, look, he's an academic. He's a Duke. That's like, it'd be smart to be a Duke. Don't applaud Duke. Don't do that. No, we don't need that here. So he is statesly, gentlemanly, and I am none of those things. I am simply a dock worker that they put in a suit and gave a podium to. Okay? So I say that because what I want to do today is really talk about trying to learn something, trying to laugh a little bit, trying to make you think. I'm not here to make you agree with me, okay? And Don's an academic physician, so he had to be nice to you. I'm one of you. I don't have to be. I spent 10 years in governmental public health. I worked at Deanna when I was at DSHS. I worked here in Texas. I worked here in Georgia. I worked in Philadelphia before that. So, yeah, you're public health heroes, and that's awesome, and I think you're the greatest people ever, and I love working with you. But this is not that time, right? Like, I think Eli Manning's a great quarterback. He's 0-4. I don't think it's the time to talk about how great Eli Manning is right now. Right? That's like, you know, it's like when Arthur Blank started dancing before the Falcons won the Super Bowl. You don't do that. Patriots fan, born and bred in Boston. So this is my contact information. Hopefully someone is tweeting here. I think the tweeting stuff is important because it lets our voice get heard by people who wouldn't otherwise hear it. So please tweet often. You may not have heard about the Beaumont Foundation. This is one of those things to Google after the conference, www.thebeaumont.org. We are a foundation of public health people. I had my 10 years of service. Our CEO had 40 years at CDC. We are people of public health trying to do good in public health. So it's worth checking out some of the stuff that we're doing. The Build Health Challenge that Don talked about is something that we do. We do a lot of other things that it's worth checking out. Now, let me just start with a baseline. Who here is angry? This is good. My goal is to really make you more and more angry. So the basic thing that rolls through my head pretty much all the time is I'm mad as hell and I'm not going to take it anymore. Right? And I don't think we have enough of that in public health right now. We're very good at golf class. Yeah, we're really good at the golf class. I like you like me. Let's hug. Okay? We need less Captain America and more Hulk. Okay? And so, because right now, I don't think it's necessarily obesity that's our problem, I think it's our approach. Our approach is the problem. Don talked about it. 3% goes to healthcare. I think it goes to health. 3% of what we spend goes to health. And so Don always says, Brian, why are you so critical of physicians and healthcare? Because you have 97% of the money. When it's equal, I'll stop saying bad things about physicians. Like, is that a fair kind of balance? And so when you really think about it, we've had medicine for a long time, taking their square peg and jamming it in a square hole, right? That's what we do. It's bugs and bacteria. That's what we do. We do this well. We cure. But then something happened. Chronic disease outpaced infectious and acute disease is what kills us. And the hole changed. And they looked at the hole and they went, oh, now it's a round hole. I have this square peg. I'm sure as hell going to jam it in there a whole hell of a lot harder, right? Everything changed, and we didn't change the healthcare system. Now, I love this article. This is my favorite. It came from the New York Times, okay? I have a quote from this article. No city seems more in need of improved heart care than Camden. 42% of the population lives in poverty. Obesity is rampant, as are high cholesterol levels, high blood pressure, and smoking. The local hospital's cardiology department has long felt pretty cocky about how it was doing. Heart care is the hospital's specialty, and without its revenue, it would have to close its doors. Let's just sit here for a second, shall we? You angry yet? So what I propose is we should go to Camden, which is a relatively poor community, and we should put, what? Fat in the water? Maybe half-price cigarettes? Who's for half-price cigarettes in Camden? Because if the cardiology unit's revenue is the issue, and they need unhealthy people, then we should make people as unhealthy as possible. Right? This is the New York Times. And the New York Times missed this point. They did an entire article celebrating buying bigger and more buckets. Okay? We're a sinking ship. Let's be really clear. We're a sinking ship. We spent a whole debate, ACA, Obamacare, Trump care, your care, my care, our care, whatever the care was. And that was for sick people. A lot of the same sick people. And that works. Care is really important. I want us to get care. But when we're into bugs and bacteria, care is a little more important. Because you can bring someone back to health. I had syphilis on Monday, I took penicillin, I don't have syphilis anymore, I'm now healthy again, okay? I am a type 2 diabetic. I was diagnosed at 41 with an A1C of 10.4. I know, I worked hard at that, don't you think I didn't? In 3 months it was back to 6, right? Because I have all the privilege in the world. I have fruits and vegetables delivered to my doorstep, my spouse cooks, my new gym membership is paid for by my employer. I can leave at 4. I have flexible hours. So all I did was I neglected all that privilege, got myself sick, and I will never be healthy by definition again. I will always be a type 2 diabetic. There's no pill or procedure that's going to actually get me to health again. And that's why we need to actually focus more now with the diseases that we have on prevention. And we're not doing that. Now, what I want us to do is think about 5 strategic moves that we can do as leaders, because we are leaders, in our systems and our organizations to try to get to where we need to go. Because if you ever hear this whole thing like Wayne Gretzky, he went to where the puck would be, right? You've heard this? Okay, that's because Wayne Gretzky had a play. Like he knew where it was supposed to be and he was going there. We don't have a playbook right now. Right? We have hospitals opening up public health departments, and then we're kind of going like, hey, what about us? Right? We have folks just, money moving around. We just had the HHS secretary resign. Like things are happening, and so we have to take control of this and really start thinking about some strategic moves that we can make. First among them, we got to stop with the program stuff. Okay? I ran programs for a long time in practice. Programs end. And what happens the day after the grant money goes away and the program ends? It's all still there. All the problems. We're Band-Aids, right? Our programs are Band-Aids. And sooner or later, they fall off. And when the programs fall off, then what do? We need to stop thinking about programs and move to thinking about populations. And probably our biggest challenge to this is the way we're funded, right? We're not funded to actually our health needs. We're funded to whoever can write the best grant, right? And you ever see these places that are really successful in grant writing, you ask them, how do you get so much money in your health department? Oh, we have a grant writer. It has nothing to do with your health. It has nothing to do with your ability of your staff, right? And so we're actually not allowed to kind of work through our collaborations and grade our funding. And a lot of times our own advocates, right? I'm the diabetes advocate. I'm the heart disease advocate. Well, they're fighting for their own little silos, right? In this beautiful way, we've kept everyone fighting amongst themselves and failing to make population progress for us all. So we do this. Right? If the other side of this fence was improved population health, we keep trying to look through the holes. I run the diabetes program. I run the heart disease program. I run the maternal child health program. But we're missing those things that are so important. Poverty, education, equity, housing, transportation. We're only going to get to that together. And so we need to find a way to start working together. And I would even challenge our own organizers. Are we here in this obesity summit, are we perpetuating those silos? Are we bridging them? Have we created another stovepipe? I don't have an answer to that, but it's something worth reflecting on. Who's not here? Who should have been here? Who could have helped us? Are we reaching out to the right partners? Stuff for us to really think about. We have to go from clinic to the community. There is simply no pill, vaccine, procedure, scan, other medical intervention that can increase the access to fruits and vegetables, that can get us exercising. It's not about pills and procedures anymore. There's nothing that we're going to do except treat people and get them more and more medically involved as their disease progresses. We have to get into really the community and dealing with our community issues. I get what syphilis is. It's a bug. I can kill it. Can someone tell me what diabetes is? Now, I do this exercise a lot, and I'll tell you, you can't. Because you're going to tell me a bunch of things. It's an autoimmune disease. What does that mean? Well, it's a reaction of this and this. Oh, it's okay. No, tell me what it is. Tell me, like, one day my body was like, yo, I'm done with the insulin thing. I'm out. Well, why'd you make that decision? I don't know. I'm just sick of the way you eat. Oh, but wait a second, he eats really well and he has diabetes. Talk to his pancreas, man. I'm out. I'm not here anymore. Well, okay, why? We don't know. These are systems failings. So you can't kill it, right? You can't do the Tony Fauci, we have Ebola, I'm going to save us all thing. Remember when Tony Fauci from NIH, we have Ebola, we will develop a vaccine, and I will save you all. I'm a physician. So we will get a vaccine for Ebola, we will get a vaccine for Zika. Given time, we know how to do that. What are we doing? What is that vaccine for chronic disease? We'll actually get there in a second. Look at that. So this was in Philadelphia. My mother-in-law sent me this. So isn't this what you do? I was like, well, at least someone knows what I'm doing. So who gets kidney stones? Middle-aged white dudes. Middle-aged white dudes tend to get kidney stones. Who's getting kidney stones in Philadelphia? Young girls of color. Why would young girls of color be getting kidney stones in Philadelphia? Well, fortunately, there were some really good physicians. There are a couple. And they actually said, well, wait a second. This doesn't make sense. So we can treat this clinically, but we need to think broader. We need to go from clinic to community. Because something else is at play here. And what actually was happening is when you went into the schools and you looked at the water fountains, they were, and let me use an extraordinarily technical term in environmental health, pretty nasty. Okay? And so the girls weren't drinking water. So they were essentially dehydrating and then developing the kidney stone secondary to the dehydration. So tell me what clinical intervention is, which pill is going to work here? Which procedure? Anybody, what would you prescribe? Water. Right, and I don't think that's something you need to go to medical school to figure out, right? And so we don't save those kids, we don't get those kids healthy if we're not thinking in the community and working with community leaders to fix that problem, not medical leaders. So I keep talking about pills and procedures. This is the balance, right? We don't need more pills and procedures. We need more policies and partnerships. And almost every conversation that we have about health in this country quickly devolves to pills and procedures. Instead of policies, partnerships, wealth, equity. Because come on. Yeah, what's easier? You can take a Prevacid and have a pizza, or you can not eat a pizza. We can talk about, a new fancy treatment, or we can talk about you stopping smoking. Or we can talk about how we're going to roll out, urgent cares in a community instead of talking about the legacy of equity and inequity that is really plaguing that community. Which is easier to talk about? Is the latter ever the easier conversation to have? And so when you look at some of these, in a city of 1 million residents, a 40% expansion of transit led to an annual health benefit of $216 million. Early childhood education is a 5-to-1 benefit to cost ratio. After rehabilitating housing, 60% of adults have excellent health compared to 33% before. Each time, the earned income tax credit increases by 10%. Infant mortality drops by 23.3 per 100,000. Policy is the vaccine for chronic disease. Okay, own that. That means that we have to do a lot more as public health professionals around knowing how to promote policy, talk about policy. And trust me, again, remember I told you I worked in government public health. I know the lines. I know we can and can't cross. I know that we're not going to be out there in the legislature lobbying, for this and that. I get that. But we have to be better at it. We have to figure out where our play is. Because this is, let's be really clear. Future improvements in population health aren't going to come from a lab. They're going to come from a legislature. They're not going to come from a clinic. They're going to come from a county commission. And that's where we have to get really moving with policy. And soda taxes were a good start, and we're starting to actually see, did I say that in Atlanta? I think the Coke people probably know. They're just like, there's someone in Atlanta saying something about your soda taxes. Get here. Hopefully I'll be okay. So this started in Berkeley, and then it spread to 3 other cities in California, and now Chicago and Philadelphia. And this is where we're going, right? This is where the puck is going. Okay, and that's an example. I want to make sure that at some point you Google these two things. City Health and High Five. City Health is something we did. It's 9 policies that were identified by an expert panel. And we then rated whether these 9 policies were in the largest 40 cities in the country. 9 cities, 40 policies, 360 cells, if you will, that could get medals. Only 171 of those cells were filled. There's a lot of policy opportunity there. High Five are 14 policies from CDC that will get you action, that will show evidence-based changes within 5 years. So these are evidence-based policies. These aren't just trivial policies. And I need to tell my policy story. And I know I'm going to be running late, but so really quick on the importance of policy, because it's something that really impacted me, and it was a really poignant moment for me. We rented our first home in Washington, D.C. when we moved from Atlanta. And the entire floor in the kitchen was sagging. And eventually there was a hole in the floor. And so I threatened to sue, and they said, fine, we have lawyers. And I said, well, I'm not going to pay the rent. And they said, fine, we'll sue you. You can't not pay the rent for that. So here I am. I'm a middle-aged white guy. And I have all this power and all this privilege, and I could not get my kitchen floor fixed. So what do I do? Now, what that power and privilege lets me do is pay out the lease and leave. That's what I could have done. I could have just paid the whole, because you owe the balance of the lease. If you leave in Maryland, I could have just paid that and left. But then I get this knock on the door. It's the city of Rockville. I'm like, what are you doing here? They said, oh, we're here to inspect your property. I said, for what? And they goes, well, you can't rent a property in the city of Maryland, in the city of Rockville, unless we have inspected it. And within 48 hours, that floor was fixed. That's policy, right? That's the power of policy. That's how you make sure that housing is lead-free and housing is mold-free and that it's not causing asthma, it's policy. This is the one piece I always like to bring up because this is the biggest difference and the biggest challenge that we have. If eating cornflakes gave you gonorrhea, there would be a pretty big outcry. There I was. I ate some Rice Krispies treats and I now have gonorrhea. Like everybody in the world would be like, it'd be first on the news, like da da da, gonorrhea gate. MSNBC would have one position, Fox News would have a different position, Facebook would say something else, it'd be all very confusing, but there would be a reaction, right? But there is an entire kind of corporate industrial complex that benefits from keeping us addicted, fat, and afraid. And the only reason, the only reason that you're allowed to purchase soda on Snap is because those people pay for the lobbying dollars that get to the congressman. There's no other reason. And when USDA says, we do it because we don't want to stigmatize the SNAP recipient. Really? You stigmatize the living daylights out of the WIC recipient. So can you explain that to me? Like, I don't care why you're making these choices, but just be consistent. Right? If you're going to lie to me, just be consistent with it. And that's all I really ask. I will just spend a quick moment. The entire natural history of the obesity epidemic lives in electronic medical records and we can't get to it. 500 cities, county health rankings, all the data you talked about yesterday, that's the data we have. It's not the data we need. We need XY level data. We need to get our money back on the $27 billion investment that we made in electronic health records. That's our money, that's your money, that was taxpayer money. I want the return on that investment. And that's getting those data back. Every time you go to a physician, height, weight, height, weight, height, weight. What if we could actually take all of that, aggregate it with the address level data? A lot of us are responsible for the name-reported HIV and AIDS data in our cities, in our communities. So you'll trust us with that, but you won't give us height and weight at the address level because of HIPAA? Okay, that's just you not wanting to talk to us and you just use a scary acronym to make us go away. Okay, we're public health departments. We have HIPAA provisions that allow us to get those data if we so need them. So we need to find this kind of transition from big data to small data. Now, from small data to big data. This is my last one. This is really important, okay? I want us to think about a new model of partnership. Now, the way that we often work is we work in a kind of a vacuum of power. It's our grants, it's our health department, disease is our purview. Really think about it like health in all policies. Health in all policies, okay. You're sitting there, you're making eye contact, I know don't do it because I'm going to call on you. So in your family, I want you to do me in all policies in your family. So everything in your family has to focus with me somewhere in it. Are you good with that? No, you shouldn't be. If you're into that, that's weird. But it's why would you do that? Me in all policies. It's your family. But no, we want health in all policies. Which finger do you think transportation pointed at us when you hear about health in all policies? Just asking. Education. Health in all policies. What about education? I care about education. I care about transportation. I care about my family. It's really hard for me then to say I'm going to need you in my family. It's a power grab, right? It's about ego. We have to move differently. We have to move to strategic orchestration. General Motors in the 1950s, because they had such a market share, were able to ignore technology changes, regulatory changes, competitive changes, and they did it for a long time, and what happened to them? They went bankrupt. Okay, I'm going to give you a simple metric. and I want you to really think this through. Take this one home with you. I don't want you to ever measure your partnership success by the number of times you invite another sector to talk about your grant. I want you to measure your partnership success by the number of times you're invited to talk about someone else's grant. When transportation invites you to their table, then we're effective. When education says, I'm doing this grant, I need to invite you in, because I understand that health has a role here, then we're effective. Really simply, to close, I'm getting the time up sign, you have two choices. You make excuses, or you make progress. I can make all the excuses with you, I've lived them. There's not enough money, oh my God, the staff is underpaid, we're under-resourced. That's not changing. That's how it is. You are under-resourced, you are unpaid. I battle with my weight every day. I eat a donut and I gain 5 pounds. It's just what I am. So I can whine about it, or I can figure out what to do about it. I want you to leave here, and as you drive home, figure out one thing that you're going to do differently than you did it today. One thing that you heard at this conference that'll make you do something differently. If you go home and don't change anything, then all this was a nice trip in Atlanta. You have to either make excuses or make progress. And as Tom Petty taught us, don't back down.
Thank you, Don. Thank you, Brian. I wish Brian would really tell us how he feels. So the microphones are open. If there are any questions that you have, we have really a very short window, so there is no opportunity here if you're not wanting to be bold. You've got to make it happen pretty quickly. We have about 10 minutes. Once again, if you can just say who you are, then go ahead with your question.
Hello, Jeannie Solis from Louisiana. I've been asking colleagues around the conference the last few days if they know about how this large body of data collected by hospital community health needs assessments is being compared or analyzed collectively, cumulatively, to at least reinforce what we're doing. Are you aware of any efforts through American Hospital Association, other watch groups, etc., that are doing that? And I know in Louisiana our hospital association is not, although there might be a community here or there that are tackling it. So just curious about that opportunity we have and how it's being addressed.
I think this starts at, you can wait for AHA and hospital associations and others to do this, but I think the best model is what they did in Health of Chicago. The health department took all the community needs assessments, which are on the website, compared them, and said to brought the hospitals together and said, hey, guess what? Your 3 top needs, though in different order, are the same amongst every single one of you. So you can start to work together, or you can continue to work separately. And actually, look, here's the map of all your service areas. They overlap too. So we have a choice. We work together, or we continue to have, Danny the diabetes guy go into this community, while Dave the diabetes guy from the other hospital comes, and then Darren the diabetes guy comes from the other community, and we just waste our resources. So, I think we can wait for the hospital associations to do it, but you also can hit them with the data, because it's not that hard to kind of pull them down from those websites and just start saying, look, here are the top 3 for every hospital in our community, and they're all the same, so should we work together? Right? And make that efficiency argument, and make sure that there's a way that that they can share in the glory when things are going well. But there are hospitals out there who truly believe that communities are not a pipeline of patients for their health system. And we need to find those folks.
So I'll add to that. I think there's kind of the big things, what can we do? I think there's the upstream part, and this is the development. One of the things I do with my...
Just a bit closer to it.
One of the things I do is I teach 2 courses. I do one on health systems and one on health markets and policy. And what I do with the students is they go out to a rural community to learn their EMT training, which is not a bad idea to begin with. But what I have them do is while they're out in Kinston, North Carolina, say, you're going to go online, look up the community health assessment done by the health department, look up the community health needs assessment done by the local hospital, and then I want you to interview 2 health professionals in that city, and I want you to interview 2 non-health professionals. And the insights those kids come back with are incredible. And yes, I'm only doing it 40 kids at a time, but we need to kind of build that into the way folks think as we're doing their training, and that's one of the pieces. So I think there's kind of lots of different places. I think health departments have a specific role, and like Brian said, as a convener and at one level, kind of a neutral, relatively neutral group, you've got a lot of power that you don't necessarily recognize. But I also think we need to build the pipeline so that when kids come out, they understand the need to really think in a systems fashion.
And I'll just quickly add that here in Georgia, well, here in Atlanta, the Health Policy Center, we actually did the health needs assessments for about 5 of these systems. So we were able to say, same population, same problems, duh. And to that extent, it's made a difference. So I think you're right. If there's at least somebody paying attention, health department, academia, whoever it is, to what folks are actually coming up with, there's probably a way to get folks to actually work together after that's done. Yes, ma'am.
Hi, so I have a question about the Build Health Challenge, and I promise I'm trying not to make this a grants question, more of a systems level question, but I'm with Go Austin, Vamos Austin. We were in the final round for the Build Health Challenge, and we didn't make it, and a big part of what hurt us is that we had an in-kind match rather than a cash match from the hospital. And the hospital we were working with is under this crazy healthcare umbrella where the foundation is actually where they push cash out. And the hospital told us they were not actually able to make the cash donation. They'd have to do it through the foundation. And so we explained that, but in the end, we got penalized for that. And it was really tough in that 6 weeks between round 1 and round 2 to try and get in this giant network. I mean, even getting a hold of the COO to figure out how we could operationalize this thing was really challenging. And so my question, I swear I'm not looking for like, why didn't we get this grant? But my question is really just, what advice do you have in terms of really breaking into these behemoths of hospital systems, especially, I'm happy we're at Southern Obesity Summit, lots of us live in states that didn't expand Medicaid. And so the vast majority of hospital returns are going into charity care. So what advice do you have in terms of breaking into that and getting upstream in the big hospitals?
So the reason that you want to follow the Beaumont Foundation and me on Twitter is we're going to have an actual hospital report coming out with strategies on how to break through into the hospitals. The immediate answer is get ready for round 3, but start working that hospital champion. Those grants are, in a way, supposed to weed out folks who don't have that existing relationship with their hospital. And so I think it's the worst thing to do, like I'm a funder, so when you come to me to pitch me, you're not going to be successful. When you come to talk to me about something we both share a passion with, you're going to be successful. And sooner or later, we're going to come around to giving you a grant, right? So how do you start working with that hospital with your shared goals? How do you find a hospital champion? Have that, not the COO. The COO cares about numbers, right? Find that hospital champion in there who's going to be your advocate to the C-suite. And I think that's the way to go. I need to apologize. I have an unwieldy flight to catch, so I'm going to have to go. But Don's coming with me, but I know. But
Someone's got to carry his bag.
But we're all going to be, and I don't want to steal your thunder, but we are available through text and email. We actually answer our emails and our texts and our Twitters. So if I can leave you with one thing before I bolt, stay angry, my friends. Thank you.
Can you join me in thanking them both? I wish Brian luck in catching any flight over Atlanta after speaking about Coca-Cola and the doctors. He might be back before we know. All right. Are there other questions? They're not here necessarily as a need to answer, but I think there's probably some wisdom in the room. And we can probably, if we can't answer the question, just say, hey, we'll send Angry Brian. it might be that it's time for us to actually say farewell. And so I'm going to use this as an opportunity to just thank you all for being present. I'm going to invite Michelle, if you could stand by. Let me try and summarize what I think has happened here today. And then there are a couple of announcements that I need to make. Not just today, but for the last couple of weeks. You heard Brian ask you to probably be reflective. Think about the one thing that you might do differently when you head back home, as you think about how you're going to deal with this issue of equity and really understand disparities and conquer obesity. And I would encourage you to do that. Maybe it's as you leave, maybe it's on the aircraft, when the flight's delayed, still getting really angry, just take a note out, put a note down. So I think we've heard a couple things. One is that in tough times, though the tough times might last long, that the tough don't give up. And so I would encourage you in the work that you're doing, not to give up. It's hard, the level of programs for many of you. You've heard, maybe programs not all. What Brian said, it was like, hey, stop the programs. There's still a place, I think, because we're not starting from scratch. It's what is the ramp to the highway that we're trying to get to. And so as you do this, who are the partners? What are the levers? What are particularly the policy levers that you might be engaged in making happen to see greater effect with regards to your work? And then the last thing I'd say to you is, in this army, it takes both drill sergeants and colonels. And we're all different in terms of getting people to the conversation and getting to yes. I think we need sometimes to be really angry. Well, this is not enough. It is not good enough. And then there are other times when we need to be shrewd to understand how do we become those partners that get invited in to have these conversations. Sometimes if we're too militant, nobody invites us anyway. And when we're too quiet, nobody knows we exist. And so it's very important, I think, for you to think about where you are and what's the kind of right constitution and the timing. Maybe you're bipolar a little bit. One day you're the next day in an effort to get the work done. Because in the end, the people of the South, they are relying on us to be the advocates. And with that, I will ask Michelle to bid you farewell. As she comes, I wanted to thank some folks, and she'll probably do some more of this, but Atlanta Strong for Life, Georgia Shape, Children's Healthcare, y'all sponsored that thing last night, and it seemed to have gone really well. And so I want to echo kind of thanks. And I appreciate the Atlanta Beltline Partnership, who also kind of helped to make last night happen. And the Atlanta Track Club, who I think made this morning happen and helped to support some of what you all did this morning. I'm assuming you walked this morning. How many people walked? Ran. How many people ran this morning? How many people walked while the others were running? All right, and then the rest of you were sleeping. Good for you. All right, could you welcome Michelle as she comes to tell you bye?
I can't follow Chris. Thank you all for being here. I know most of you have participated as attendees, but a lot of you have participated as presenters. I think it's been a great dialogue. I feel like we have a good ending. Chris has been fabulous. Georgia Shape and the Department of Health has been wonderful sponsors. Clayton back there has been a rock star as far as making sure our PowerPoints got loaded on time and happened. And we're thrilled about coming to West Virginia next year. I think it's beautiful. We've got some passionate people that are already so excited about what they want to share and working with us next year. So hopefully you go home. We're going to send you that evaluation. We're going to let you know about the PowerPoints. Hopefully we have some videos that you'll be able to share. Go safely, and we'll see you next year, I hope. Thanks.
So I want us to end in the way that we would you stand with me, please? Okay, I have one more announcement here. For those attending the USDA snack meeting, the meeting is on the international level, which is one floor down in meeting room 4, and it starts at 1 p.m. Once again, if you're attending snack, the meeting is on the international level, room 4, one floor down. All right, finally, this group of Muslims